Hi, everybody. Welcome to this session. We're going to look at the continuing healthcare assessment process. And we're going to start this now because ultimately your apprenticeship is based upon your fundamental understanding of this. And I need you to get your heads around this because ultimately you need to start practicing. We need to start doing lots of case scenarios. And equally, I want you to be able to think about the people that you work with and whether or not they're going to be entitled to this, because that's why we're doing this apprenticeship. So you can see on here, there's 4 key areas on the screen. We've got understanding the checklist. We've got navigating that decision tool. So once the process starts, we've got understanding the fast track pathway, and then we've got the referral form. So in this session, we are going to look at the first part, which is understanding the continuing healthcare checklist. Now, with anything, if we are going to do an assessment, the patient must be involved, the service user must be involved, and the family member. What I particularly like about the gateway, the Gov gateway that we use, when we log in, all of the paperwork you're going to need here. Look, so on screen, there's an easy read document. There's a patient leaflet there, and they've got it in easy read format. So if you are going to conduct a continuing healthcare assessment on somebody, it's fundamentally important that they understand which assessment you're going to do and why. So let me get the one up that we're going to do. We're not doing fast track. We are going to do the checklist. Okay, so here's the checklist. And we've got the checklist with a referral form. I'm going to, actually, no, I won't do the PDF one. I'm going to do the Word one. And the Word one is the one that you're going to use. So we will bring that up now on screen. Good. So here it is. Continuing healthcare checklist. We know it's the most current one because we've gone online and taken it off online. If you start saving these documents to your hard drive, you never know if you're using the right form. If you're not using the right form, it's automatically going to get rejected. So don't do that. Always enable so you're ready to go, and then you can type in. Now, I'm not going to read this to you because obviously you're adult learners. You can read this by yourselves, but I'm just going to pick out the key points. So here, what is the checklist and why are we using it? It is a basic screening tool. It's just going to cut out a lot of stuff. It isn't the be all and end all. It's a screening tool, and it will allow you to come up with a positive or negative outcome, and it will allow you to decide whether or not you're going to do a referral. It obviously meets the guidance, so you need to make sure that you have read the framework, the national framework there for continuing healthcare and funded care, and be familiar with the tools, because again, it's the same tools that we're going to use. Throughout the process, it comes up with 2 outcomes, a negative outcome and a positive outcome. If it's negative, it means that they do not require a full assessment and they're not eligible. But if it's a positive outcome, it means we can refer them, but it doesn't guarantee that they're going to pass. Okay, so it doesn't mean that they're going to get money at the end of this to contribute towards the care. It's just the tool. Okay, so, and again, just be mindful about completing things, and they've got a bit about their logo, etc., etc. So just make sure you've read those. If you're in the NHS, you'll have information governance policies to follow, so make sure you're following all of those there. So when should it be completed? Now, there's lots of different times when it should be completed. If you know the guidance, if you've read the NHS guidance, it will tell you on the National Framework page 9, so just follow those because it'll tell you when it is and isn't suitable. We're not going to cover that here. We're just going to cover this form, but we will cover the National Framework and cover the key points in that. Equally, it talks about discharging, and it talks about people who aren't eligible. Obviously, if it's end of life, that may be fast track, people that are under a 117 section, because again, if they're under a section, if they're under the Mental Health Act, then they may not be eligible because they're already being treated, etc. So just make sure you're aware of those guidances. So how should it be completed? Relatively straightforward. We have a form. We're all used to filling forms in. We're all used to screening tools. We're all used to assessment decision tools. We have domains. So for it to be positive, it tells us here what the requirement is. So 2 or more domains selected with column A. So if we've got 2 domains out of the whole list with column A ticked, that is a positive referral. Or alternatively, you could have 5 or more domains in B, so a minimum requirement for B, or 1A and 4B. Okay, so it's a combination. So if you're going to say this person is ready for referral, go back to this and make sure you understand it. Now, at the bottom of the form, it asks for a justification. It says, why are you referring this person? It's relatively straightforward, isn't it? After conducting the assessment tool, I can confirm in line with section 19, they have met 2 or more domains of A, or they have met 6 or 7 domains in B. Now, just be mindful that some of the A's have a little star by them, an asterisk. If they have that, it doesn't alter this process per se. It just means if you've got some of those stars with an A, part of your justification will be they are a priority. Okay, and this will make more sense as we go through the tool. So there we go. We've just talked about that. Good. So what happens following this? Well, you're going to inform people, you're going to prepare for the full assessment, or you're going to get a letter. So you should have 2 letters as standard. One letter that says, today I've conducted the assessment, it's come out negative because, and obviously people, if they want to appeal it, they can, but it's unlikely it's going to change at that point because if they failed the checklist. However, where it can be reasonable and anticipate the individual needs are to be increased in the next 3 months. So if we're thinking about an increase, that's there as well. But then what happens if it's a positive? Well, it does refer you here. A positive checklist means we can refer them for a full assessment that they would be eligible. Doesn't mean they're going to get it. But again, if you go to the national framework, it will tell you the process of what to do for that positive checklist. What's important is that obviously you shouldn't leave somebody without the appropriate support. So regardless of the decision, if you think somebody needs something, you should still be preparing and planning for that, because obviously you are working within your duty of care and safe ways of working. So let's have a look at this checklist. Page 1, relatively straightforward. It is what it is. It's just a form. Date, name, who it is, GP. Address is really useful because you're going to need to write to these people about the outcomes. Gender, again, for equality and diversity monitoring at the back, really important, especially if you start getting accused of being discriminatory or something, you need to have your data there. Thinking about involvement, were people involved and consulted, and again, who are those people? So again, part of data sharing, bit of consent there for data sharing, exactly. And equally thinking about capacity and consent as well, making sure you've got the right frameworks in place before you even start. Accessible information, basic understandings of rights. And again, here it just says you will not screen if it is any of those there. So again, doesn't hurt bring out the checklist and say, right, let's just run through these criteria to make sure that it's okay to do this. Tick, 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 tick. Yeah, great, we can carry on. Good. So let's just imagine we've got Bob. He's Bob Smith. He's 82 with COPD. It affects his activity of daily living. And we're going to run through Bob as we cover each thing. So first of all, first thing to notice is that breathing is a priority. It has an asterisk here. So we know if we tick A, in our judgment at the end, we have to think that's priority. We can't waste time here because, again, it's a bit like our breathing, 3 Bs or 4 Bs in first aid: breathing, bleeding, bones, burns. If we're not breathing, we've got a problem, right? So we don't need to be a rocket scientist on this. C. So Bob's got COPD. It's definitely affecting his daily living. He's not getting quality of life. He is really, it's really causing him distress. Where would we think that sits? C, B, or A? So if we look at C, that's normal breathing, no issues or shortness of breath. So it's definitely not that. But then all of a sudden, or shortness of breath. Well, yeah, he does have shortness of breath, which requires inhalers. Well, yes, he does take a steroid. He may have a nebulizer, but it has no impact on activities of daily living. So we're probably going to rule out C because it does impact his activities of daily living. Then we move into B. So here we've got shortness of breath, requires an inhaler, and limits some of activities of daily living. So here, straight away, we now have our first B, don't we? Because what we're saying here is Bob does have shortness of breath, and it does really impact his activity of daily living. So here, we're going to pop. Oh, we're going to write B. Because those silly little boxes that they give you obviously don't line up. Why would they? But we can do that. Okay, now let's just make sure it's not an A because it is an asterisk and A is really important. So is able to breathe independently through a tracheotomy. So he doesn't have a tracheotomy. Breathlessness due to conditions, which is therapeutic intervention. He is responding, it's just deteriorating, so you're not going to get away with that. Or a condition that requires the management of non-invasive devices, both stimuli, breathing, non-invasive, positive airway pressure. So he's not on ventilation or anything like that. So we're comfortable it's B. Now what we've got to do, we have to give the reason why. So it's asking for a brief description and the evidence to support this. Now, you could do our SABR situation. Bob, 82, diagnosed struggling with breathing, activities of daily living. Background, diagnosed with COPD in 2023. Assessment, I've done his lung capacity, results are, I've done his vital signs, results are, oxygen levels are, peak flow is. Whatever it is that you've done as the assessment goes in there. Recommendations, well, what is it we're hoping that we're going to do with Bob? Does he need support? Does he need one-to-one? Is it the fact that he needs to do lung therapy? Whatever. So you could use SABR to help you write this. Or again, if you are a nurse, you might want to do your nursey care planning bits. So again, give me 2 secs and I'm going to pop some text in there. Okay, so let's pop that in there and let's see what I've put. So I've put presenting issues. Bob reports concerns related to his breathing, respiratory and well-being. Current medication, just list what they are there. Respiratory assessment, so what is it we've done? Breathing patterns, listening, oxygen, sounds and SATs. Activities of daily living, how does this affect his activities of daily living? Environmental factors. So again, can he get upstairs? Is he on a flat? How does this really affect him? And then recommendations. What am I hoping that's going to come off the back of this? And then obviously some kind of plan of care for that, because I'm just saying, look, this is what I'm thinking. People may or may not agree. Good. Okay. We now go to nutrition, food and drink. So here, Bob's 82, he's got COPD, and let's say he has short-term memory loss with some swallowing problems that are under investigation, and he's not able to independently get himself food and drink. So kind of like you more socially care bloke. Okay, so here we now have to look at this. So C, able to take adequate food and drink by mouth to meet all nutrition requirements. No, but does he meet this one? Needs supervision, prompting with meals, may need feeding and or a special diet, for example, to intolerance or allergies. Possibly. Able to take food and drink by mouth, but requires additional supplementary feeding. So again, that continual support. We move up to B. Okay, so needs feeding to ensure adequate intake for food and takes a long time. Now, this is the short-term memory bit and the struggling. Half an hour or more, including liquidized feeds. So, is it taking a long time for him to eat? And if it is, what's the evidence of that? Okay. Or unable to take food and drink by mouth, but all nutritional requirements are being done through PEG, so through PEG feeding, and then right up to full risk of choking, you know, all at risk, significant weight loss. So when we think about it, we may be thinking, well, okay, look, Bob's 82, he's not able to manage his own food and drink. He does need somebody to get it for him. He's got short-term memory and he is very slow. So is that where we're sitting at? Is that where we're sitting at? The problem is we now need the evidence for that. So if you're not recording in your care plans or your care notes how long it takes to support somebody to eat and drink, you're never going to have the evidence. So it's really important, if you are assisting people to eat and drink, that you are recording the time it takes, because to pass this threshold for B, you need that time frame. Okay, so it's really important. Now, when we think about evidence for this, we're going to have maybe food and fluid charts. Maybe we're going to have a medical report about throat, swallowing, reflex. Maybe we're going to have a report from a dietitian. Maybe we're going to have a referral, something from the SALT team. So again, let's just pop those in there. So let's pop our notes in there. So we've got our presenting issues. So we're going to start off with by telling the person, look, these are the issues. He has challenges with food and drink. He's just not getting enough in. He's got problems with swallowing, and that's going to extend his meal time. Obviously, what's really helpful there, are there any current medications? So is there anything there to help? Then we're going to go for nutritional assessment. So what is it that has made this a B, not a C? So we've got his dietary habits. We've got the swallowing difficulties, requiring 45 minutes to consume a basic meal. But again, where's the evidence? So you could just write, we have evidence of 6 months or 4 months or a month's worth of care plans. Were there any changes in weight and any oral healthcare, dental problems, teeth, ulcers, whatever it is? So is it a temporary problem or a long-term problem? Again, some evidence of that food and drink, how that impacts the activity of daily living, any environmental factors that are going in there, and again, then your recommendations and care. So if you had all of those problems going on, I'd be quite happy to go, again, let's level that up. I think that would be a B for Bob. Good. Let's move on. So continence. Now, here's the one. Continence management. Okay, so Bob's 82, we've already said he's got a little bit of problem with his memory. He does need a lot of encouraging to maintain his continence hygiene. So actually, he needs reminding every couple of hours about going to the toilet. He can be doubly incontinent at times, and obviously because of that, he can get quite agitated and aggressive. So just think about those things. So I'm probably describing a very typical person in a residential home for nursing care. Or in residential home that should be in nursing care. Good. So C, fine, no problems. Continence care and routine day-to-day basis. Okay, incontinence of urine, but that's managed through toilet and regular toileting. Or maybe some kind of device that's going to help. And or it's able to maintain full control. Maybe because they have a stoma or something else, but it's managed. That would be a C. B looks at the continence care needs the routine, but requires monitoring to minimize that risk. So is Bob at risk of moisture lesions and pressure care? Is he doubly incontinent? Does he end up with lots of UTIs? And is there a problem around bowel management? Or is it A, thinking about what we talk about, the challenging and more aggressive behavior, is the continence care slightly more problematic? Does it require time and skilled interventions? So do you need a positive behavior support plan? Or do you need a behavior plan to manage that? Is that over normal routines of just supporting somebody? So I would go, if Bob, when he's doubly incontinent, becomes challenging, it's got to be an A, right? It's got to be. So here we've got now our first A. Now we're going to pop in what's going on here. Give me one sec. So we can see here presenting issues. We talked about Bob being doubly incontinent, and we talked about some of those behavior issues there. And you can see I'm following the same format: presenting issues, current medications. So water retention, lactulose, whatever it is, what is it that's being there? Or as part of the behavior, is there PRN medication there to manage behavior? Looking then at the continence assessment, what was done by whom? Is he known to incontinence team? Then we're going to have to go into some of those behaviors. And again, we're going to need that information much further down on the interventions that manages Bob. Because if you've worked with people, first of all, it's their dignity, it's the privacy bit, it's the whole embarrassing bit. So of course we're going to get behaviors that can sometimes challenge or be hazardous. We're going to look at the activities they live in, look at those environmental pieces, and then recommendations, and then plan of care. So again, based on all of that, we'd be happy to put Bob there. Probably a little bit more evidence just to tighten that up, but hopefully we can see where we're going. Right, let's move on. Looking then at skin and tissue viability. Now, because Bob is doubly incontinent, of course, there is a risk, it's just a risk, of moisture lesions. He's 82, he's not getting a good intake. So let's have a look. But at the moment, there are no pressure sores or anything else to consider with Bob. So let's have a look. So no risk of pressure, damage, or skin conditions. Well, we can't say there's no risk because there is some risk there. Risk of skin breakdown, which requires prevention interventions once a day or less without skin integrity, wounds would break or would break down. Well, every couple of hours because of the moisture lesions, etc. Maybe. Evidence of pressure damage and or pressure ulcers. Well, there isn't any of that. And a skin condition that requires monitoring or reassessment less than daily, that's respond to treatment. Okay. Let's see if we can get it into B or A. Risk of skin breakdown requires preventive intervention several times each day without skin integrity would break down. Moisture lesions, etc. It's such a difficult one. because it is tissue viability. You could argue it. You may get battered down to a C, but you could argue it. Pressure damage, no, because there's no open wounds there. As skin tissue requires minimum of daily treatment. So it's not really that one, is it? But it could be that. It could be that. And again, pressure cared, open wounds, specialist regimes. So the problem is it is probably more a C, but we know if we want to get Bob the help, he may have to be a B. It's a bit of a give or take. I'm going to go because Bob is 82, because he's got doubly incontinence and there's some confusion there and he's not eating well. It is a risk. Because when we dig deeper in the full assessment, we can decide, have I been a bit generous there? So again, I would just say it is a risk. So here, again, I'm going to pop my B in there. I'm not as confident on this B because I think maybe it is a C, but we'll try. Presenting issues, the client presents with concerns because it is a risk related to skin and tissue viability, because he needs that constant cleansing, because if we didn't do that, his skin would break down. Also because of the dietary thing, is he at risk? Presenting, I think, yes, you could deteriorate. But anyway, list the medication, list your tissue assessments. Have you done a water lows? Have you done pressure marks? What, have you done anything there? Again, pop in what some of the challenges are. So again, we've talked about healing. We've talked about the nutrition. You could talk about the incontinence. Again, environmental factors. It may be the fact that he can't get to the toilet. So what's going to be your recommendations and then your plan of care there as well. Good. So we've got another B. Okay, mobility. Well, Bob is moving, so he is independently mobile. He just needs encouragement. So he is able to weight bear, but needs some assistance. So we're going to get a C for that. But this is where it changes. So if consistently weight bearing, and it's such a jump, isn't it, from I'm able to do this to I'm not able to do this consistently. So it's the evidence in which you're going to need to mark that up to a B. Or needs position in bed at moderate risk of falls. Now, so again here, this again. So he could be absolutely fine, but has he had falls in the past? So we may need just to look at his fall history. There isn't any that we can see. So it's still probably here, but with, that's not there. Or alternatively, we're looking at needs complete help, unable to move, high history there. So again, here, we're going to write C. Sorry, Bob. Can't give you a point there because when they come out and assess you, you are able to weight bear. Here, that's what we're going with, but we may just need to add a bit more information. So looking at Bob, obviously presenting issue, we've said, look, the client presents with mobility challenges. He is able to weight bear, but requires assistance, which is pretty much word for word what it said there. Medication, useful to know, especially if it's on blood thinners, especially if it's things for hypertension stuff, because that may give you an indication of risk of falls or something like that. The assessment, so what assessment tools have you done? So looking at, I can't remember one of the names of the tools for mobility, but you've got your weight bearing tools, you've got your functional assessments. It may be the fact that OT have done assessments. So if you think about B and A, there's the likely scores that you can have. There's a kind of how hard is it to move and handle somebody. There's the board score. I'm trying to, off the top of my head, I'm trying to think of different assessment tools. So use an assessment tool to justify that there. Again, equipment needed for activity to daily living, environmental factors and recommendations. Good. So we went for a C, didn't we? Okay, communication. So Bob is able to communicate. He's able to see what he's thinking. He doesn't really need any assistance. English is the first language, so no real problems there. I think this is relatively straightforward here. They communicate with some difficulties, or maybe need an interpreter at times, or it is unable to kind of communicate. So even that implied consent, they just can't get it. So again, here we can see that Bob is able to communicate effectively. So that would be another C. And here I'm just going to put he's able to communicate his first language. Okay, now thinking about the psychological and emotional needs, depending on his challenging and aggressive behavior. So if Bob is being supported 4 times a day to go to the toilet, and 4 times a day he's becoming quite aggressive or angry or challenging, this is the bit where we have to kind of work out, okay, why, what's going on? Is there a mood disorder there? Is he known to the mental health team? Does he have something on his medical records? You know, we talked about a bit of memory loss. Are we waiting for a diagnosis of dementia? Is there a past history there of maybe paranoia, schizophrenia, psychosis? What's there? So here he wouldn't be C, would he? Because it is having an impact. So we need to then move up and kind of find out where we're sitting. The mood disturbance, it's not necessarily hallucinations or anxiety series. It's more anger or aggressive and hazardous behavior. But it could be due to their psychological emotional state. So it could be here. Equally with Bob, it does cause severe periods of distress. That mood disturbance around toileting and the anxiety of toileting could cause severe periods of distress and could be having a severe impact on his well-being. So again, due to the psychological and emotional state, the individual has withdrawn. So it's not that. So it could be A or B. It's more likely to be B. It's unlikely you're going to get an A there unless you've got lots and lots of evidence to support that. So we can put B in there. And again, here, we can put that in there. And we will put that in there about toileting. So here, I've obviously put about his psychological and emotional history, more based around his presenting issues, which is the angers and triggers around his incontinence and short-term memory. So that kind of makes more sense. But again, what assessments have been done? What is the evidence? So we've done maybe withdrawal assessments or triggers or coping mechanisms, or maybe there's a report from psychiatry, or maybe you've got functioning assessments, ABC charts. Maybe you've got lots of incident reports, whatever it is that shows this, how it affects the activities of daily living, his environment, and again, some recommendations there. So cognition around his memory, we've said he's got a short-term memory problem. We don't know that it's dementia yet. So no evidence of an impairment, confusion or deterioration. So it's not that. Cognitive impairment, which requires some supervision, prompting, activities around daily living, finance, medication. Yeah, could be that, couldn't it? I've just got to prompt you to go to the toilet. Granted, it gets a bit more challenging because of the behavior around kind of the anger and stuff, but on the whole, it could be there. Occasional difficulties requiring, maybe not. Cognitive impairment, which requires some memory issues, some supervision, care of activities they live in, some awareness. No, not yet. The individual is usually able to make choices appropriately, but needs assistance, right up to obviously cognitive impairment. So he's probably a C because Bob best fits in this one. You know, we've got the basic risk of skin breakdown. Without the supervision, he's not going to eat or drink. But again, we are saying he does need supervision. But that does give us a C, I think, for that. Again, depends on the evidence that you've got, right? Behavior. Okay, so this is the bit where, you know, especially when I teach the control and restraint, the RRN standards piece, and everyone's saying, no, we don't do restraint. It's not about doing restraint. It's about the intervention so you don't have to restrain. And most of those interventions require additional staff. So he's definitely not C, because there is no evidence of challenging behavior, because there are. Some instances of challenging behavior, a risk assessment indicates that behavior does not pose a risk to self or others. Well, I don't think you can call it that, because when somebody gets angry, especially if they're doubly incontinent, body waste can be hazardous, especially if someone's lashing out at you. So there is a risk of infection, there's a risk of cross-contamination, there's a risk of him having feces on him and then attacking him and result. I mean, there's lots of risks. And with the confusion as well, and if it's going all the time, does that then pose a risk? Does it pick up? Is that what the evidence is saying? So again, could it be B here, challenging behavior that follows a predictable pattern? Well, it is a predictable pattern. We know it's every time he goes to the toilet, he becomes aggressive and angry. The risk assessment indicates a pattern of behavior that can be managed by skilled care workers who are able to maintain that level of behavior. Yes, at the moment they can contain it, but is always compliant. And that's the bit, because I think as somebody gets more confused and the confusion kicks in, you definitely start to move up towards A. So at the moment, I think we are there based on the fact that Bob's care plan does seem to work, the strategies do work, but it requires a lot of interventions there for Bob. Notice the asterisks. If it was an A, you're going to become priority because people shouldn't be at risk. The reality is, I think at the moment with Bob, we're on a B. So here we can see the presenting issue. He follows a predictable pattern because we know it's when he's going to the toilet, medication, then your assessments. So what assessments have you done? Functional assessments, predictability assessments, etc. How it affects the activities of daily living, your risk assessments. So again, depends on the risk assessment here, would depend on, maybe the risk comes up as an A. Maybe you start at B and you start to think, oh, actually, no, we can't manage this. Again, looking at the interventions and the recommendations, does that keep it at B? And at this point, I'm happy that it does. And then obviously your plan of care. Good. So it almost feels like a big old care plan, doesn't it, really, as you're going through it, you're ticking it off. So drug therapy, looking at medication, side effects, etc. So symptoms are managed effectively without any problems. Medication is not resulting in any unmanageable side effects. So again, no, his meds are fine. Actually, he's working well. Requires a bit of supervision. Well, he will do, because that's short-term memory piece. And again, he could be in a bit of mild pain. He could have all of that for C. B, does it require by a registered nurse or care worker due to non-compliance or the type of medication or the route of medication? Or is he in moderate pain? So again, ultimately at the moment, I still think we're getting away with a C there. Or is it an A? Does it require administration and monitoring medication regimes by a nurse or care worker with specific training? So again, risks of pain. So moderate pain or high levels of pain. So you might be talking about your patches, your controlled drugs, stuff like that. So again, probably a C there for Bob for now. but it absolutely could change. We've got no idea what goes on. It may be the end of this care plan. You're like, no, Bob definitely needs it. So again, and it's the supervision bit. He requires supervision, but that is what it is. Altered states of unconsciousness here. So if Bob is beating you up and Bob's getting upset when he's going to the toilet, it's a C. But again, that may change. And actually, if you were up on the higher end, you'd probably be thinking of a fast track assessment anyway. So again, brief description there. So total from all pages. So now what we've got to do, we've got to add up how many A's, B's, and C's we've got. So we've got 1 C there. We've got 1 C there. We've got a B there. I don't know how this is going to work out. It's the first time I've done this. We've got a C there. We've got a B there. We've got a C there. Let's just see there. What's a B there? We've got an A there. We've got a B there. Another B there. Right, so let's go up and remind ourselves, so number 19, wasn't it? Number 19 up here. Let's remind ourselves what the criteria was. Okay, so it says for a full assessment, 2 or more in column A. We had 1 in column A and it wasn't an asterisk, so it was 1. This is 5 or more domains for column B. 1, 2, 3, 4, 5. So we had 5 in column B. So actually, we had 5 in column B and an A, meaning it's a positive outcome. But he had 1, 2, 3, 4, 5 in column C as well. So he just scrapes through 1, 2, 3, 4, 5 B's and 1 A, meaning it is a positive assessment. So let's go down here. And in our box down here, we can now write total from all pages. So we've got A, 1, B, 5, C, 5. Oh, 5. Good. That's the outcome. Total from all pages. That's where we're at. So is this now a referral known as a positive, or is it not a referral? Rationale for decisions. So we are going to do this. We are going to put that there because Bob, why is that capitals? Bob has a total of A equal A times 1 and B times 5. And then here, we may just want to do a narrative of the ones that he scored. So when we scored that one up in A, we'd go back to it. Oh, there it was. Well, why did I see that? We've got B. Oh, I don't know. Let's have a look. B. So we had B for breathing. So we had breathing. Just making a note. Breathing. Food and drink. Breathe in food and drink. Continence. Okay. So again, down here, we can just do a summary. We can say, look, because the main issues for Bob, so the main issues for Bob are around breathing, COPD, that is making drinking well as so. What I do is I just type that in there, okay, and I'm going to copy that, and I'm now going to go to my wonderful AI friend. Please rewrite for a rationale for decision for a positive outcome. There. So you don't have to use obviously all of that, but we do have the tools there, and it just puts it into, it just makes it a bit easier for the next step. So the more details you have in here, the easier it's going to be for the next step. So again here, look, we've got the findings. I've got the reason for the A because that's the top one, the activity on breathing. I've summarized that there. So if you want to read the whole form, you've got this here. So again, S, just there, today's date, pop your details in there. And again, about you, equal monitoring form here. So just complete your equal opportunities form. That then is the end of that form, and we are then going to prepare that for the next steps. So hopefully you found that useful. You're going to do some case studies. I want you to start doing these on the people that you're working with, because I need to know that you're able to fill these in and come up with some judgments. So thanks for watching. Hopefully you found that useful. Take care and bye for now.